It actually is, with, again, an honor to introduce, Dr. Tanner, Chris. And, I have her CV, in front of me, and, it's long, very, very long, and she is, a professor at Oregon Health and Science University. And in fact, it is so long that I have to scroll down here on my iPad, okay? But Chris has been very involved in a variety of different things throughout her career, in her work with Pat Benner, and her work in clinical judgment, as well as her recent work within the Oregon Consortium for Nursing Education. What I didn't want to do from an introduction standpoint was just read through her CV. I wanted to share with you actually a story, and I'd mentioned to Chris actually yesterday that I was going to share a story about how we met and how much of an influence that meeting had. And her remark was, well, are you telling your side of the story or my side of the story? And so, my side. In any case, it was a late winter night. No, just kidding. Through Dr. Ed Keenan, rather, I had the opportunity to actually meet Chris because, again, in the grapevine at our organization, there was the notion that other people were interested in simulation, and in particular, Dr. Tanner had some interest, and so I said, okay, well, let's meet. And so we actually met in her office, and it was interesting because right at that moment we recognized we each had something that the other wanted, and we had experience in simulation and some background in it. She had interest in simulation and the space. Okay, and from there, really a real relationship evolved between disciplines and that again traditionally haven't always worked together, and we actually established the first simulation facility at Oregon Health and Science University. What was remarkable about the story was again the relationship and the trust that embodied that relationship. And how that grew and really permeated into the program that evolved from that one meeting. And it was really an honor to be involved in that. And I really take it as an example of what can be done when people work on relationships and put aside their personal professions and biases. The other thing that actually happened, in all this was really Chris's work and that of others in the Oregon Consortium for Nursing Education, where there was this almost symbiotic relationship that actually occurred, an opportunity that occurred as we formed something called the Oregon Simulation Alliance. And it was really this opportunity where the OCNE actually really had a lot of innovative programs and things that they were doing, and in particular one area was that of simulation, and they really were actually one of the reasons that the Oregon Simulation Society, the Oregon Simulation Alliance, actually succeeded, because they again had the trust in the organization to actually again help in the implementation of the simulation end of things and in training individuals and increasing capacity. And so really it has been a huge adventure and a wonderful adventure, with Chris. Without further ado, I would actually ask you to, give Dr. Tanner a very warm welcome, and I'm sure you're going to enjoy her presentation. Thank you.
Thank you so much, Michael, for that nice introduction. I was pretty worried about what stories you would be telling, but we as Michael indicated, we started this very successful collaboration now almost 10 years ago as we were starting some innovations around nursing education in Oregon, largely in response to the nursing shortage and largely in response to shifting needs for what nurses needed to know and be able to do. And simulation really gave us a foothold in that as an innovation, as a different way, really, of thinking about educating our students. And this reminded me a little bit of conversations that Michael and I had. Michael feeling sort of downtrodden in the School of Medicine where people really didn't understand what he wanted to do with simulation. And he'd say to me, it's always sit, stay, heal, never think, innovate, be yourself. So together, we established the Center for Simulation, contrary to popular belief, in the West, or the Pacific Rim, at Oregon Health and Science University that started out as an interdisciplinary center, and we continue to work toward goals in terms of interprofessional education. At that time, though, it presented a new way of thinking about education as we began to see the possibilities in simulation, raising the question of what are our educational goals? How is it that we could actually design learning activities in a simulation environment, design clinical experiences that would help students achieve those goals rather than take the clinical that just comes to us, that's available to us, that may or may not help students develop in certain ways. And I have to say that the move towards simulation was really revolutionary for many of the leaders in the consortium in thinking about education of our students in new ways. So my purpose today, though, is to talk with you about how the research in clinical judgment across many disciplines really might help us get clarity about educational goals that are framed toward teaching students this important skill, raising the question, in fact, can we teach this skill? With clarity about goals, we have better ideas about how do we prepare students for simulation, what kind of scenarios do we need, what's the nature and complexity of scenarios that are really needed if we bring into focus, bring into stark relief educational goals related to thinking like a professional, educational goals related to clinical reasoning. What does debriefing look like? Is it the same as or different when we focus our energies toward learning clinical reasoning? And what does assessment of students look like if we really try to evaluate this important competence? Is it possible? So I've had the privilege of working over many years in the study of clinical judgment, clinical reasoning, beginning in the mid-'70s. And as many of you know, I'm sure there have been parallel activities in medicine and nursing, each discipline separately exploring what does clinical reasoning look like in their respective disciplines. And interestingly, very little, well, not surprisingly, I suppose, very little overlap between the two disciplines in our research and our efforts. But nevertheless, both have developed in similar ways. First, let me get some definitions out here. That when I think about clinical judgment, I think about the conclusions that the clinician reaches about a patient's health status and or about intervention management decisions. And what makes it a judgment is that it occurs under conditions of uncertainty. So interestingly, for beginners, everything would be considered a judgment because everything is uncertain, while for an experienced expert clinician, many things are very routine and do not appear to be uncertain conditions. Clinical reasoning, by contrast, are the processes by which these judgments are made and evaluated. The typical research questions in these fields of study, there are three, there are actually many more, but the first question that was taken up in the disciplines was the question of what are the clinical reasoning processes. The 70s and early 80s saw a lot of research efforts directed toward the process, looking for some general process of clinical reasoning. And we learned pretty quickly that there isn't a process that actually, or a process certainly that distinguishes an expert from a beginner. In fact, everybody kind of does the same thing, and that the process used was not the thing that was going to help us distinguish between expert practice and beginner practice. Research moved on to questions about then what is the role of knowledge and experience? How does this influence the development of clinical reasoning? Can we understand how knowledge is structured in such a way that it informs our clinical diagnosis and management? And then what factors influence judgment? What factors impinge on it? And here again we have many studies looking at both clinical and non-clinical factors that affect judgment. And there are a number of investigators, the number of investigators contributing to this field in both medicine and nursing is actually pretty small, but it's been quite productive, and you can really trace how work in both fields has evolved over the last 30 years, and I'll try to capture some of this in my comments. But I really want to just have a conversation with you, I think, about how this research will inform the work of simulation. So in our work on clinical judgment, then, we have found that when a clinical encounter is begun, when a clinician first encounters a patient, when a nurse walks into a patient room in a hospital, when a nurse picks up the phone and telephone triage, they engage very quickly in a reasoning process that somewhat simplistically might look something like this: of noticing when things are not awry, noticing what things stand out. Very early in the encounter, clinicians will pick up on cues that indicate that something is awry with the patient in front of them. I'm sorry, I lost my place here. Now, beginning clinicians are often overwhelmed with the sheer amount of data in front of them, that things don't stand out as important to them. And this is one of the key items that come out of this area of research, is this notion about sense of salience, that information to the experienced clinician simply stands out. But beginners simply live in a different clinical world. They see very different kinds of clinical signs. Now, I was recently in Italy, and this kind of brought this notion home for me again. It's really helpful to remind myself of this. This is, many of you recognize, I'm sure, the Sistine Chapel ceiling. And I had very little background in art history, and frankly, after seeing many, many paintings looking somewhat similar to this as we traveled through Italy, visiting every museum, I think, in the country, many looked alike. But my son, who had studied art history, was able to point out to me all the salient features of this and what the meaning behind this was and why this was such a profound piece of art during the period it was there. He could see so much more in the paintings because of what he knew. And that's so much the case in our clinical encounters, is that the experienced clinician is so able to see so much more than what the beginner can see. And it's really a process of coaching that helps the beginner be able to see the relevant cues in that situation. We all know have had the experience of working with a beginning student who's done a complete health assessment or a complete physical exam, and they've totally missed the relevant cues. They fail to notice what's important in that situation. So let's take a look at what sets up noticing. What makes it possible to notice? Because this is really the trigger to trigger or engage the clinician in a clinical reasoning process, is to have something stand out that isn't immediately explained and that leads to some action or lack of action, if it's deemed appropriate, in the clinical situation.